This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Shuvro Roy from the University of Washington, and welcome to today's Neurology podcast. Today, I have the pleasure of interviewing Louise Oaklander, Associate Professor of Neurology and Director of Peripheral Nerve at Harvard Medical School. Today, we'll be discussing her recent article published in Neurology titled Relapsing-Remitting Immunotherapy Responsive Small Fiber Neuropathy, Longitudinal Tracking Through 10 Years, Including Pregnancies. Louise, in this study, you followed a single patient across 10 years of her clinical course of a relapsing-remitting small fiber neuropathy, which I think provides us just so many insights into a disease course that most of us are not familiar with. Could we just start by taking us through your understanding of really how small fiber neuropathy classically presents?
Small fiber neuropathy is a class of peripheral neuropathies that primarily or exclusively affect the small fiber neurons. I call this class of diseases hiding in plain sight because there's increasing evidence that this may in fact be the most common type of peripheral neuropathy, but we haven't seen it because these axons are so teeny tiny that they're not visible under light microscopy, and they're not detectable by EMG and nerve conduction studies, which have been the major tools used to study peripheral neuropathies in the last 50 years. Different technologies are required to interrogate these small fibers and diagnose them and track the patients, some of which were used in this paper. The gold standard currently is the use of skin biopsies taken from the leg, typically the lower leg, which are used to count the number of small fiber nerve endings in the skin. So again, small fiber neuropathy patients classically will have normal ENG and nerve conduction studies. Some of them may even have apparently normal neuro exams because this class of neuropathies does not affect the motor fibers. So I think these are the reasons why it's escaped the notice of many neurologists. The most common symptoms of small fiber neuropathy are difficult to characterize. I think that's helped with the large fiber neuropathies because patients have visible muscle atrophy, fasciculations, and weakness. You can't miss it. In contrast, these small fibers have multiple different functions in the body. They're responsible for maintaining homeostasis in our organ systems and for protecting us from danger. And so therefore, patients present with a whole constellation of variable symptoms. There's no one classic presentation. And for that reason, like the blind men and the elephant, these patients get referred out to different specialists for their GI symptoms, for their cutaneous symptoms, for their cardiovascular symptoms. And the majority of them never even actually make it to see a neuromuscular specialist and to get the appropriate testing. And therefore, most of them currently remain undiagnosed and untreated in the community. So the things to think about that might clue you into this, I think the one most people are aware of is chronic pain. But there can also be chronic itch, paresthesias, any type of sensory perturbation. In about 3/4 of the patients, this starts in the feet distally, but in 1/4, it may be patchy, proximal, or involve the whole body. There also are a whole host of what I call internal symptoms, POTS, disturbances of blood pressure and heart rate, tachycardia, are very common. Many patients present with what's called exertional intolerance, used to be called chronic fatigue. And research from our group, but many others around the world, have established that roughly 50% of patients labeled as fibromyalgia or chronic fatigue, CME, in fact have skin biopsies diagnosing small fiber neuropathy. So interstitial cystitis, irritable bowel, it goes by a lot of other names.
I'm glad you bring that up with regards to many of these patients being undiagnosed. In preparation for this interview. I happen to have a patient who was referred to me, and I am a neuroimmunologist, usually typically seeing patients with multiple sclerosis. And this patient presented to me and had been told that her symptoms were due to fibromyalgia, or that she best fit into the bucket of fibromyalgia. But as we did some digging, it turns out she had some relapsing remitting symptoms of erythromelalgia. She had dysautonomic symptoms. She had chronic pain, many of the symptoms that you have just described to us. And classically, when we think about small fiber neuropathy, we're not necessarily thinking of somebody with a relapsing remitting course. And so I am curious, even though it is outlining the course of a single patient, you were able to follow this single patient over 10 years through multiple different events and different treatment courses of their life. I was wondering if you could discuss the significance of using a longitudinal case study like this, and then how it informed your findings.
Single case studies have fallen into disrepute, but in fact, this was the classic way that neurologic and other diseases were diagnosed and characterized, is by following individual patients. And you can't really set up to do large, highly powered clinical studies until you have gathered the data from small patient series so that you know what you should actually set up to study in the large series. Yet, unfortunately, current medicine is focused on cross-sectional research rather than longitudinal research, which is much harder to do. This patient was exceptional in that she herself was a scientist, and she had been careful to collect the data about her health condition in a very careful, thoughtful way. I met her perhaps 3.5 to 4 years into her course during her second episode. And then, in fact, she was doing a postdoctoral fellowship at Harvard and later moved back to Europe to continue her productive career. Kudos to her, by the way, for being able to continue to be employed full-time despite this disabling illness. So all credit really is due to the patient for pulling this together. And among the co-authors are the physicians who cared for her in Europe. So it was a team approach with an exceptional patient at the heart that permitted us to generate 10 years of data. My team has also been NIH funded, thank you very much to NINDS, precisely to develop the metrics that would permit this type of longitudinal study. And I think this study showcases the importance of using standardized approaches. Speaking to a neuroimmunologist, it really makes me think about the diagnostic criteria for multiple sclerosis. I was conscious of the seminal importance of diagnostic criteria in other areas of neurology, specifically thinking about the McDonald criteria for multiple sclerosis.
Before we get into this patient's course, you mentioned that you used a small fiber symptom survey to help delineate exacerbations from baseline, for example. Could you tell a bit more about the survey and how it might be used in practice?
We validated and published the SSS for diagnosing small fiber neuropathy, and we showed that it performed well. It had good psychometric properties when compared to the gold standard diagnostic tests of skin biopsy and autonomic function testing. So again, although it's not perfect, I do think it's useful. The SSS validation was also important because we validated it in a group of patients with small fiber neuropathy from multiple different causes, including what I call initially idiopathic SFN. If you look back at the metrics for peripheral neuropathy, almost all, I think it's like approximately 90% or more of metrics were validated in patients with diabetic neuropathy to study that. And so they really can't be assumed to perform as well in other samples. So the SSS was developed specifically for use in this population. We also applied the magnet neurologic exam was helpful, and that is a standardized exam. It's a quick, focused neuromuscular exam targeting the most important signs to detect on exam for small fiber neuropathy.
This helped to delineate relapses in this patient. And speaking of that, could you take us through the 10,000-foot view of this patient's course over the 10 years that you followed her?
The essential graph demonstrating the patient's course was figure 2, which only covers episodes 2 through 6. Episode 1 had happened, again, 3.5 or 4 years before I met the patient, so we didn't have such detailed metrics. But if you look at the number of data points on this graph, you can see that this patient was redoing this online symptom survey. It's in REDCap, just over and over repeatedly, multiple times a month. And it's only all credit due to her for documenting this. At a practical level, what we found is that a cutoff score of approximately 5 in her case differentiated just small levels of symptoms that were within the normal range or else developed at the end of IVIG cycles as each one was wearing off from the true flares. The many different therapies that this patient took are graphed in at different times. And in looking very carefully at this, one does get a sense of which therapies were and were not helpful. You asked me for an overview. I'll summarize very briefly. This was a previously healthy young woman who I believe, as I remember, was in her 20s when this began. So she had no risk factors for neuropathy whatsoever, yet she became quite ill with an erythromelalgia, which is a sensory and distal microvascular abnormalities in her feet. There's a photograph of her feet during episode 2, which shows you clearly the visible erythromelalgia. Her neuropathy was confirmed with a skin biopsy. Detailed testing, which is in a table in the paper, to make sure, really exhaustive testing, to look for causes of neuropathy, and nothing was identified. Interestingly, we did not identify any blood markers of immunity in her, nor a history of previous autoimmune diagnoses. So I think this goes to show you that these blood tests do not always pick up what's actually happening in the immune system in the vicinity of the nerve endings. Just as a patient who has autoimmunity in the brain, this may not always show up on peripheral blood testing. But basically, I and then her doctors in Europe did go on to treat her with various immunotherapies. Corticosteroids were highly effective in the beginning. And during episode 2, I treated her with prednisone, which induced, you can see on figure 2, an almost immediate near remission. She jittered around at baseline for a few months and then really went into a prolonged clinical remission. And then when she relapsed again, this time she was treated with immunoglobulins, pooled immunoglobulins, because knowledge had emerged since then that these might be effective, and it was a better long-term option. Her treatment history was very much complicated by the fact that she had 2 pregnancies and was trying to develop a family. I laughed when you read the title of our paper. It's a very clumsy title, but I cannot tell you how much attention went into wording and rewording that title, because we were trying to put into the title several concepts, including, and pregnancies was a key word, because there's next to nothing in the literature on how to manage immunotherapy or even any treatment of small fiber neuropathy during pregnancy. Just as with multiple sclerosis, these patients tend to be young. Not everyone, many of the patients are young women of reproductive age, and this has been truly neglected in the literature. So I felt it was essential to tuck that word pregnancy in despite the word limits for the title. Because of her family planning, we had the essential participation of her hematologist oncologist, who's a co-author of this paper. And she used her much more advanced knowledge of immunotherapies to be able to manage this patient in a much more advanced way than I think most patients would have access to.
You're right. Pregnancy just does make it just that much more complicated anytime you're managing someone on chronic immunosuppressive or immune modulating therapy. I would strongly encourage you to go and review the figures for this paper. One, so you can clearly see, it's rather remarkable just how often this patient was completing the survey and seeing truly how well the symptom survey scores seem to line up with different events, whether it be pregnancy, whether it be variations in treatment. And then also the table, I think it serves as a terrific reference for those of us who are evaluating patients with this sort of presentation for what we need to be testing for. Most of it from the serum, but particularly also helping us with our differential. I think one of the clear aspects here that oftentimes I am faced with patients who often overlap is, as you mentioned, this patient did not have typical autoimmune markers, at least from the serum testing. You sent in a comprehensive set of labs here, and they were all negative. But clearly, this patient responded to immunotherapy. And so I am curious, how did the immunotherapy responses in this patient advance our understanding of small fiber neuropathy's autoimmune aspects?
I call this type of small fiber neuropathy apparently autoimmune or disimmune because we do not know yet what the smoking gun markers are. Again, we tested for what we could. It was negative in this patient. Even in multiple sclerosis and long established neuroimmune conditions, we don't yet necessarily know in every patient what the exact molecular targets are, and we're making fundamental molecular discoveries, such as the role of EB virus infection. How recently has that come out in a disease that's just been so long known in neurology? We're all flying by the seat of our pants, and that's why I'm cautious to call this apparently autoimmune, which means based on best current knowledge.
You also just mentioned Epstein-Barr virus, and it feels like not that long ago that I was sitting here interviewing Alberto Escario on that exact paper published in Science in 2022. But what was also interesting about this study, or in this patient's case, was that viral infections seemed to trigger many of the patient's episodes. So what does that suggest about the relationship between infections and her exacerbations?
Infections are a long known trigger of not only peripheral neuropathies, but brachial and lumbosacral plexidities, indeed encephalitides. The underlying thinking is that sometimes the immune system goes awry. I would like to draw your attention to an absolutely fantastic paper published by one of the leading teams studying small fiber neuropathy in the world, the team of Alain Créange and Jean-Pascal Le Faucheur in a suburb of Paris. And so their paper was published in a neurology journal as well, is called Characterizing Acute Onset Small Fiber Neuropathy. The strength of their paper is that it is larger than ours. It is a cross-sectional more than a longitudinal paper. And they studied a series of 20 patients as well as some other control groups. And they showed that this was a series of patients who had the acute onset of small fiber neuropathy, as our patient did. They defined that as reaching the maximum illness spread and severity within 28 days. So their series is complementary to my study in providing a larger group. In their group, 80% among their patients had a precipitating event, and the vast majority of these were infections or a few vaccinations. The only other signal that emerged, which should be always kept in mind with acute neuropathies, is the possibility of intoxication. So it's important to screen patients to make sure there's no toxic exposure. Of note in their paper, 4 or 20% of their patients, they do mention in the paper that they also had a relapsing-remitting course. So I think their paper provides additional supportive evidence in a larger cohort to support the concepts that we developed in this very in-detail study of a single patient.
One other similarity between different autoimmune conditions is that variations in sex hormones may be associated with changes in autoimmunity. And certainly with this patient, it seemed that pregnancy played a significant role in her disease course, even including pregnancies that were not carried to term. Could you elaborate on the implications of this for managing small fiber neuropathy in women of reproductive age, as you hinted to earlier?
There's so little data gathered on both the effects of estrogen and other changes in pregnancy, not to mention how to manage during pregnancy, that we are truly flying by the seat of our pants with this. I have managed the 3 or 4 patients, or maybe a few more, but no more, really, a handful of women with small fiber neuropathy that I've managed during pregnancy have all done very well. And so I think that's the biggest take-home message. I don't think women with small fiber neuropathy who are contemplating pregnancy should fear it or should, delay pregnancy for fear of harming their fetus. I truly have not seen this happen. And I and other physicians have been able to continue to manage the patient's symptoms successfully, finding treatments that have not, in any way that we know of, harmed either the fetus or the baby.
Absolutely. And do you feel like there are broader lessons on how to approach the treatment of small fiber neuropathy?
Again, I think we have to be very cautious extrapolating from a single case. The 2 types of immunotherapies that I think there is reasonable interim guidance, it's not perfect. None of these papers are making it into the New England Journal, are corticosteroids and intravenous immunoglobulins. Again, none of the studies published are perfect. My group published what I think may be the largest case series of 55 patients that had objectively proven small fiber neuropathy that was idiopathic. All other causes had been excluded. And this was the subset of patients, again, that had apparently autoimmune neuropathies. So we had evidence in those patients that led us to believe that in that patient, the cause was autoimmune. In this group that had been treated with high-dose IVIG, we started at doses of 2 grams per kilo per 4 weeks, which is the standard for clinical trials in IVIG, and then titrated downwards. We reported very respectable outcomes. As I remember, about 2/3 of the patients improved. We did something that I would encourage others to consider, which is that we included an objective outcome measure, autonomic function testing scores, not just patient pain scores. There are 2 other studies that, again, have great strengths that tested IVIG in different types of small fiber neuropathy patients. Those, unlike my study, were randomized control studies. The weakness of my case series is that there was no placebo IVIG. It would be very difficult and expensive to organize that. So listen, some of those patients were going to improve anyway, right? So it really, a case series that's uncontrolled doesn't prove anything. Unfortunately, both of the published RCTs did not study the groups of patients that would have been ideal. One study, very nice, large study from Europe, specifically excluded all the patients with evidence of immune causality. There were letters back and forth in neurology about that, pointing out that why would you study a treatment on the group least likely to benefit? But that negative study, I think, complements ours in showing that you should not administer IVIG indiscriminately. It does not help patients who do not have some evidence of immune causality. And similarly with corticosteroids, God forbid, I would never want anybody to treat somebody with corticosteroids for what turns out to be diabetic neuropathy, or to waste IVIG when it's not indicated. Another very nice study from Beth Israel Deaconess found negative results of using IVIG in patients with 2 very specific autoantibodies. My take-home message from that is that it adds evidence that those very specific 2 autoantibodies they studied, FGFR3 and TSHDS, are not actually very good markers to pick up autoimmune neuropathy. I want to specifically, though, mention the unusual treatments that were tried during pregnancy. Again, I don't want to stretch this too far. This is one patient. But one should strive to withdraw treatment if at all possible. And that was done in our patient, and she was able to remain off immunotherapies during part of her pregnancy. That's the optimum situation. And indeed, she did have a pregnancy-associated remission. It's hard to know for sure if that's causal, as has been described in MS. But she was also treated with plasmapheresis, and that is a therapy that is rarely used for chronic conditions because it needs to be readministered. It's just not technically feasible for the long run, but I think it does come to the fore very specifically in pregnancy and certain other time-limited conditions in which you're trying to get a rapid response. So Plex was effective and was used during pregnancy.
What are the key clinical recommendations that you would want to pass on to practitioners, especially those of us who are not trained as neuromuscular specialists, but obviously see these patients with small fiber neuropathy? What would you pass on?
My take-home message to all is that please put small fiber neuropathy on your radar screen, because the evidence suggests that it is not uncommon. Professor Wilder-Smith published a study in Switzerland demonstrating prevalence is higher than that of multiple sclerosis, which is something all neurologists know about. So all neurologists, I hope, will get small fiber neuropathy on their radar screen. You can't refer all these patients to neuromuscular specialists just because there aren't enough of us. So everyone in neurology needs to have some idea about how to initiate the testing and evaluation of these patients and the simple treatments. Disimmunity may be as much of a cause of small fiber neuropathy as is diabetes. I think it's different in different populations and at different age groups. Diabetes increases with age, and it's much higher in certain settings, whereas disimmunity is probably more common in young, otherwise healthy people, particularly in women. So please think about the possibility that your patient with idiopathic neuropathy, you might want to consider disimmunity as well as considering diabetes and add that to your testing. I think it's controversial about when to treat these patients, and I understand that we're all struggling with this. Some of these treatments are expensive, some are potentially dangerous. No one wants to get in trouble for prescribing a treatment inappropriately. But at the same time, this community of patients has been neglected, and particularly the young ones who are trying to launch their career, as this patient did, the children, people trying to finish their degrees, trying to have families. It's easy for we neurologists to wash our hands of the patients and say, sorry, I can't help you. But at the end of the day, I think we need to keep an open mind and consider the possibility that perhaps some, not all of these patients, might perhaps have disimmunity and be willing to at least consider that possibility.
Absolutely. As I said at the start, certainly even just preparing for this interview has opened up my mind in terms of differential when I have some of these patients who overlap in terms of demographics with MS when they present to me. Thank you so much, Anne Louise. And this has been today's Neurology Podcast.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org /podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.